This conference will now be recorded.
All right, well, hi everyone. Thank you for joining today's Fight CRC Rats Learning Lab. This is Reese Garcia, the Research Advocacy Manager. And today we have Dr. Issaka and Dr. Shankaran from the University of Washington Medicine and Fred Hutchinson Cancer Research Center. They will be presenting on their screening research around colorectal cancer. So with that, I'm going to hand it over to you ladies, and I will switch to your PowerPoint. All right, and it is all yours.
All right. Good morning, everyone, or afternoon, I suppose on your end, perhaps. So I will be reviewing some slides related to colon cancer screening projects that I'm involved in happening through the University of Washington Medicine. And these are the results of a pilot that we initiated in December of 2017. So I'll give you some background and context, review the pilot results, and then talk about what happens next. Next slide, please. Next slide. Okay, so as you all are quite familiar, colorectal cancer is the second leading cause of cancer death. And in 2018, over 50,000 men and women combined are estimated that will die from this disease, making it, of course, very important and an area of common interest between us and your group. Next slide. Compared to other cancers that are preventable, unfortunately, those who are eligible and need to be screened for colon cancer don't quite screen at the same rate that other preventable cancer patients do. So if we look at, for instance, the Pap test or mammography, we can see that overall close to 85% of those who need to be screened to prevent breast cancer and cervical cancer ultimately get the appropriate test. But when we look at colorectal cancer, we see that overall the rates are closer to 60% and have really plateaued since 2010. So this is, where this project in particular comes into play. Next slide. Within the University of Washington Medicine system, the center received a Centers for Medicare and Medicaid Innovation Award in 2015. And the purpose of the grant was to really try to improve the overall healthcare and healthcare delivery of patients living not only within the state of Washington, but the surrounding states that will also access our centers to receive tertiary medical care. One of the priorities became to try to really understand where patients were up to date with screening and not by using our electronic medical records, which in the past had been challenging to do because our EMR was being fed from so many different sources. So this grant pretty much enabled the center to hire analysts and to really sort of more thoroughly investigate the electronic medical record using claims data, using lab data, pathology, all of these different factors that play a role when we're trying to determine who's up to date with colon cancer screening or not. So what you can see here is that very last bar on the bigger graph, that total, it shows that overall in July of 2017, about 55% of those who were eligible for colon cancer screening within UW Medicine were up to date. And then it's broken down by different health entities. And so the first bar starting from left to right is Paul Health, where you see about 46% are up to date. Then we look at Harborview, where 39% are up to date. Northwest Hospital, where 57% were up to date. University of Washington Medical Center itself, where 59% were up to date. And the same goes for the neighborhood clinic. And then at the top right, you can see another graph that shows these same figures, but by payer entity. So looking across from commercial, Medicaid, Medicare, others, and self-pay. I mentioned in the previous slide that roughly only about 60% of adults who are eligible across the U.S. are up to date with colon cancer. And we know that if we can increase those rates up to 80%, it's been estimated that 200,000 lives could be saved over the next 20 years. And so this is really an issue that's important to me personally, as well as the healthcare center. Next slide. So by looking specifically at the different payer groups, a lot of different metrics, especially around screening, are tied to reimbursement. So go back, please.
Sorry about that. Is that the right slide?
Could you go back one more slide?
There we go. The last.
So screening metrics are tied to reimbursements, and one of these metrics in particular is called the HEDIS star rating. And for each screening service, there are different sort of thresholds that are set at which a healthcare organization will get reimbursed for care provided. And essentially at the end of 2017, when it came to colorectal cancer screening for a Medicare Advantage patient, University of Washington as a whole that, sort of encompassed all of those different groups I showed you, was around 63%, which put us at a HEDIS star rating of 3 stars, which is obviously not great, kind of in context of what I've already shared. And so the goal, one of the sort of aims of this grant that I had described that's funding this work was to try and improve our HEDIS star rating for the Medicare Advantage patient population to 4 stars or above in 2018, and this is a target, and then expanding that to the other payer groups as well. Next slide. So this is data from Kaiser, and this was published in 2011. And essentially what Kaiser did was, starting in about 2004, they moved from a sort of very opportunistic way of screening where patients were just recruited in clinics and offered either colonoscopy or stool-based tests, and identified their patient cohort that was eligible for screening and essentially targeted those patients and mailed them FIT kits. And what a FIT is essentially, a stool-based test for detecting microscopic amounts of blood in the stool. Patients can complete it at home, mail it back. It's very cheap. You can scale it to large patient populations, and patients don't need to come into the clinic in order for you to then involve them in the screening process. And what they demonstrated was that over the 6-year period of doing so, they were able to increase overall screening adherence from about 35% in their commercially insured patient population to about 69% by 2010. And then in their Medicare population, screening increased from 46% to 75%. And this group actually just came out with a paper earlier this week where they're now closer to 80% across their entire patient population for colorectal cancer screening, and it's all through essentially FIT for those who are at average risk. Next slide. So based on that and other studies as well, we designed an intervention for a Medicare Advantage pilot program. And what it included was an introductory letter to patients that just stated that we had noticed that they were no longer up to date with screening. And in the letter, we offer them a choice to either call in to schedule a colonoscopy, but in the intervention, we also include a FIT kit. And so we say if this is already in this package and you can complete this at home. And we included a self-addressed return envelope that sent the results back to the Harborview Medical Center lab. Next slide. And so of the eligible patients, we ended up conducting this pilot in about 950. And you can see that the majority, about 54% of those patients came from the UW neighborhood clinics. The next largest entity was Northwest Hospital, followed by Harborview. That represents about 17% of the patients in that lime green color, followed next by the UW Medical Center, Roosevelt, and then Hall Health is a smaller fraction. And what you can see here is about 182 patients returned the FIT kit, which is about 19%. And that might seem low, but I'm going to sort of show you some data that in a second that shows that's actually quite on par with what we expect. Of those, unfortunately, about 25 were discarded, but 157 were resulted. And most of the primary care providers have been notified. Some patients have yet to be notified because their charts are protected. And so we personally, from the population health management team, cannot contact them, but somebody from their primary care team will be in touch. Next slide. And what I'm showing you here now is sort of a breakdown. So of the 182 FIT tests that were returned, we had a positive rate of 8%, which is again on par with what we see in the general patient population. FIT positivity ranges from 5 to 10% in most studies. The majority were negative, and then, as I mentioned, we did have a fraction that were discarded. And the tests that were discarded were really because the sample the label was illegible, or there was a delay in the return. And I'm going to talk about how we're going to plan to overcome some of that in the expansion project. Next slide. So, I'm showing you data from 2017 of December from 2017 of December till June. That 182, those who sort of returned their fit kits, that didn't happen immediately. And so the top left, what you're seeing is just what were some of the outreach efforts that our team employed in order to get to that figure. And so there were several patients that received postcard reminders, about 731 in total. Chart reviews were conducted in about 456, and this is still ongoing. And then of those, about 200 received either a note through their eCare, which is our electronic health record, or received a phone call. And by doing these specific outreach efforts, we were able to get in total about 36 additional patients that returned their fit kit, and that's part of that total of 182 patients that I mentioned. And then in the bottom right, what we're looking at is patients who had a positive result. So there were 15 that had a positive result. And so far, 7 of those have completed their colonoscopy, so about close to 50%. And there are some that have refused a colonoscopy, which unfortunately is something that we do encounter in the screening literature. There are some patients, 3 that were deferred, and this one particular patient failed to have a good prep. One patient has comorbidities, and so even though we try to be very explicit in our inclusion and exclusion criteria, that's not always perfect. And these are some lessons learned for the expansion project moving forward. Next slide. So I mentioned that we had a return rate of about 19%, and on face value that might seem low, but I'm just demonstrating that this is actually on par with what we see with other male fit interventions as well. And so this is a study that came out last month from Allison Brenner's group in North Carolina. And what they did was they randomized about 2,000 adult patients who were Medicaid recipients to either a male intervention with a fit kit or only a letter reminding them that they were due for screening. And in the first 2 boxes that are highlighted in red, you can see that 21% of those who got the fit kit completed screening compared to 12% of those who only got the reminder. But this actually, what they did, the initial numbers were closer to 2,000, but what happened was for those patients that they didn't have correct addresses, they dropped them from this particular analysis. And so when you look at the study by randomization, the fit plus reminder return rate is actually closer to 15%, whereas the reminder only is around 8%. Next slide. And this is a study that just came out this week, from Gloria Coronado's group in Portland, Oregon. And what they did here was they randomized about 26 FQHCs over a 1-year period to either male fit or to usual care. And again, you can see that the percent of fit kit returned was 14% in the intervention arm compared to 10% in the usual care arm. And they demonstrated that overall 18% of those patients who were randomized completed any sort of screening. So something similar to our intervention where patients are being offered the option of either the fit kit or colonoscopy. Next slide. And so here's where we are today. So we started our pilot in December of 2017. And if you take a look at that larger graph all the way to the right, when I started, I told you our screening rates were around 55% for the entire UW-Medicine entity, and now today we're at 60%. Now, clearly this is not simply due to our intervention alone because it was a smaller number, but I think what happened was by initiating our pilot and having these conversations around colon cancer screening, we just increased awareness about this issue within the healthcare system, and that prompted conversations that happened outside of our pilot itself. When we sort of look at where the largest increases happen, they're really within Harborview Medical Center, which is our safety net patient population, where about 7%, I believe, of patients overall had an increase in screening participation, and then within UW-Medicine, we see a 10% overall increase. And then you see increases by payer groups as well. Next slide. So this is just a summary, just to say we have now observed a 5% increase in screening rates across UW-Medicine, with the largest increases outlined there. And as I mentioned, it's likely due to the pilot and overall increased awareness. And again, that our pilot results are consistent with what is published currently. So there are a few challenges ahead and things that we've learned from the pilot that will be integrated into the larger expansion, which is starting next week. And that will include about 25,000 patients across the UW-Medicine entities. And so really the challenges that we need to think about are how do we increase overall, screening rates? We're at 60%, which is great, better than 55, but how can we truly get closer to that 80% target? How do we increase follow-up colonoscopy completion in patients with abnormal FIT results? I showed you that we were around, 48%, and again, that seems to be on par with what we see within the U.S., with the exception of Kaiser, which is a very organized healthcare system. And then how do we create sustainable programs overall? And I'll try to address each of these in a single slide, which is challenging. But next. So we know that, from the Kaiser experience and from other groups abroad, that really in order to improve overall cancer screening, colorectal cancer screening, you need multiple interventions. And so we started by offering test choice, which you see over to the far right, by offering our patients the option of FIT or colonoscopy, but then including that mailed FIT kit so that they already had one way to screen at their fingertips. And then, and then in the top left, you see that it's the organized mailed outreach. So we did two things, but really in order to improve overall screening rates, we're going to need multiple sort of interventions. And part of that may include systematically sort of generating lists of patients who are due for screening, which is something that we're doing with the population health management team, because we're really now taking screening out of the hands of the primary care provider and doing this centrally. There are always insurance coverage and access issues. I mentioned we saw great increases in our safety net population, but access is always something that we think about within our underserved medical cohort. And, just how do we best utilize electronic health records to do this? So I mentioned that, there are some patients that even after going through a very intense inclusion exclusion criteria, we still found that ultimately perhaps they shouldn't have been screened. And how can we sort of best refine that? So those are things that we're continuing to work on. Next. The next, issue is really about FIT follow-up. And this is a large study that majority of the data comes out of the Kaiser system, but it's comparing Kaiser Permanente Northern and Southern California to Group Health, which is here in Seattle and is now also part of Kaiser, and then Parkland Health, which is part of the University of Texas Southwest system and is the safety net here. And what you can see essentially is that within the Parkland Health system, that's where FIT follow-up is the lowest. So pretty much of the patients who had a positive FIT, only 58% get a colonoscopy, compared to the Kaiser Permanente Northern California system, where 83% of patients get a colonoscopy. And this just represents very different patient populations with different resources. And so how do we, sort of improve this within our particular healthcare system? Next slide. This is my own data, sort of showing that this is coming from the San Francisco safety net system. So even within safety nets, it's important to understand that it's not a monolith. And so within the San Francisco safety net system, there are about 10 clinics serving adults. And what we found was that overall 56% of patients with a positive FIT completed a colonoscopy within 1 year. But if you look across the spectrum, you can see that you have clinics that range from 29% to clinics that are close to 76%, which is getting closer to the numbers that we see for Kaiser. And so I think part of our work moving forward is really trying to understand at the clinic level what are the resource challenges and what things are being done well, and how can we assist those clinics to amplify the impact of their work by supporting them with resources that they need to achieve these targets. Next slide. And then finally, really in order to create sustainable programs, you need to have alignment from leadership, financial alignment, and also programmatic alignment. And then understanding what are the right set of combinations of interventions for the right settings, and then really developing strong partnerships with primary care and other relevant stakeholders. And that is a lot of the work that we're doing now as we begin to think about this expansion into including more patient groups and patients overall. So I will stop there on next slide, and I will take any questions from the group.
Thank you so much. That was very insightful and very helpful as well. Just a quick reminder to the advocates on the call, you are welcome to type your questions into the chat bar. That would be probably the best way. If you do have audio capabilities, you're welcome to ask them as well. So while you all are thinking of your questions, I do have a few questions myself. So one of the questions I have relates to challenges from the provider side. So as far as Medicaid and reimbursement rates go, did you see or do you have any insight into challenges that providers might have from the reimbursement side that might affect screening rates? Is there any correlation between reimbursement and subsequent screening for this population?
So within UW-Medicine, because it is an integrated health system, the providers themselves don't necessarily have to deal with reimbursement issues. From the provider perspective, it's really about hitting those numbers of screening rates, but that's really applied to the entire organization. So it's not as if one specific provider gets dinged if their screening rate is 50% versus another provider whose screening rate is 70%. That gets averaged and it's applied to the entire entity, and then the entity, the UW-Medicine, gets reimbursed from the different insurance plans. And so in our setting, I don't believe that that's an issue, but certainly that might be an issue for providers who are in private practice settings who aren't, sort of being grouped and within a practice and receiving reimbursements that way.
That makes sense. Thank you. Another question I had related to the new screening guidelines. So now that the American Cancer Society released guidelines saying individuals should be screened beginning at age 45, do you envision that impacting a study like this, or do you think that's something that's necessary to consider going forward when developing a more robust screening program?
I don't believe that the new guidelines will impact our study. One, that guideline is really a qualified recommendation, unlike their ACS recommendation to screen everybody over the age of 50, which is a strong recommendation. So I think that's important to keep in mind. The second reason is that insurance companies have not yet stepped forward and said that they're going to cover insurance coverage for patients who are 45 or older who, ultimately get this test. And so patients need to keep that in mind, that if for screening starting at age 45, they may be paying for everything out of pocket. And then when you sort of look at the data at a very granular level as well, overall, there are different ways in which you can report the impact of an intervention. And one way is to sort of say, okay, well, what's the overall quality of one life year gained from, this particular test? And of course, if you're young, then, every year that you're able to get is going to be of high quality. But when you actually look at the number of lives saved, which is a different way of sort of assessing that same intervention, that number is very small. And so I think that, this will certainly, I think, hopefully drive home the message for screening for certain populations, for instance, African-American men who are at higher risk for colon cancer in general, and also those who have a family history of colorectal cancer. I hope that these new recommendations start engaging those populations in the conversation so that they can get screened earlier. But I think for the rest of the general population, this will overall have a very small impact on their screening behavior.
Great, thank you. And I see that one of our advocates, Lyra, asked a question as a follow-up. And Lyra, I think you have call-in access. Did that answer kind of address your question?
Can you hear me?
Yes.
Well, I'm not sure I understood your question. I'm not hearing too well. But my question is there any consideration for testing young people that are under the age of 45 with something like FIT in an environment like a college or university clinic?
I don't think that there is any utility to doing so. Again, the overall incidence of colon cancer, when we look at the population under age 45, is very, very small. And I know there was the recent papers about a year or two ago from Rebecca Siegel's group that showed that the incidence was increasing. But really, when you look at the numbers, they've gone from anywhere from 1 per about 100,000 to now 2 to 3 per 100,000 over a 20-year period. Those numbers are very small. I absolutely think for those who are under the age of 45 who are having rectal bleeding that's not going away, that's the reason to see your provider and to get tested for colon cancer. And in those incidences, FIT is not the right test. It would be a flexible sigmoidoscopy or colonoscopy. So those who are under 45 who are having symptoms like Rectal bleeding, abdominal pain, weight loss should absolutely be seen, but FIT is not the right test.
Great, thank you. And before we move on to the next slide deck, I just wanted to give everyone else an opportunity if there were any other questions on this first presentation. Okay, thank you. Shall I go to the next slide? All right.
Great. Reese, can I just ask you, do we have until 12:15, is that right? Or 1:15, I guess?
We have until 1:30 Mountain Time.
Okay. Well, I don't think this will take us very long. This is a sort of work in progress, a study that we're developing in our group and hoping to submit for an application for funding to support this study. And I think, you know, part of the goal in presenting this to your group is to kind of give you a flavor of what kind of questions we're interested in, what we're studying, but also hopefully to sort of set the stage for getting input on these kinds of studies before we launch a big, you know, randomized trial. The idea is to make sure that this kind of project would make sense and be, you know, be amenable to patients. So would love to hear your feedback on this concept. So this study is called a randomized pragmatic trial of SMS reminders, so short message service text messaging essentially to improve surveillance colonoscopy use in early stage colorectal cancer. It's sort of shifting gears from screening colonoscopy to surveillance. Next slide. So essentially, after early stage colorectal cancer treatment, patients can be at significant risk, sometimes as high as 50% of recurrence in the 5 years after surgery to treat the primary colon cancer. And there have been many studies that show that surveillance testing improves survival colorectal cancer, and the guidelines universally recommend colonoscopy within 1 year or at 1 year post-surgery. There's also recommendations to do tumor marker testing using the CEA or carcinoembryonic antigen every 3 to 6 months and CT imaging annually over the course of 5 years. But while CEA and CT use seems to be increasing over time, colonoscopy use is really consistently underutilized. And it seems, at least in our region, that adherence is around 50%. And while CEA and CT use is increasing overall, it does seem to be that, you know, we don't really understand how and when these tests are used in what populations. There's quite a bit of variability. Next slide. And we think that because surveillance colonoscopy use is so low, there's an opportunity to try and intervene to improve use of it. And it seems in reviewing the literature that some of the barriers to surveillance colonoscopy are actually not that different from the barriers to screening colonoscopy that Dr. Issaka was referencing. And so in that vein, SMS reminders or text messaging reminders have shown to improve colorectal cancer screening and seem to be a strategy that can be applied in this realm as well. Importantly, text messaging or SMS reaches a variety of populations: older people, lower income people, racial minorities. It's inexpensive to use. There's a potential for interaction on texting, and it's low intensity. And so putting this all together, we're proposing to actually study text messaging as a way of improving surveillance colonoscopy by basically addressing some of the barriers: low motivation to do the test, scheduling difficulties, lack of knowledge about the role of surveillance colonoscopy, and we plan to do this in a randomized fashion. And in the context of this study, we really want to understand sort of the mechanisms by which the intervention succeeds or doesn't, and which subgroups seem to benefit most from this kind of intervention. Next slide. And so here's the basic schema. So at the you see this big line down the middle that leads us from the intervention to the outcome. So we're studying the impact of SMS reminders to do colonoscopy on the use of surveillance colonoscopy and actually the use of some of the other tests like tumor markers and imaging. But along the way, we plan to study all of the factors that we think play into this pathway. So factors at the patient level, so knowledge about colonoscopy, perceptions around it, worry about risk of recurrence, basic demographic factors, but also physician factors. You know, are physicians actually recommending this test, and how does the physician's perception about the value of this test impact patients' ability or willingness to use it. Next slide. And so we have a few aims. This is a little bit repetition, but our basic aim or goal of the study is to determine the impact of these tests on utilization of colonoscopy within 15 months of surgery, B, utilization of tumor markers and imaging in the 2 years following surgery, and C, our ability to detect local and distant recurrence. And so our general hypothesis around all of these things is that by using these SMS reminders, we can increase colonoscopy and appropriate use of other surveillance tests, and ultimately detect colorectal cancer recurrence more efficiently than just the standard usual care that people receive. Next slide. And then, of course, as I mentioned earlier, we're trying to kind of explore more of the factors at the patient level and the provider level that sort of affect how and when these reminders are most effective. Next slide. And again, same approach, kind of studying the provider factors that affect this relationship. Next slide. Here are the basic criteria of inclusion criteria for this study. So we're aiming to recruit patients who are within 90 days from a curative surgical resection for stage 2 and 3 colorectal cancer that have not received colonoscopy in the time between surgery and enrollment, who have a mobile phone that can receive SMS, that can read English and are 18 or older, and who are receiving follow-up care at any of the high-core regional clinical sites. And high-core is basically our research group, the Hutchinson Institute for Cancer Outcomes Research, that has kind of created a partnership with a number of cancer centers throughout the Western Washington and I think actually across the state, actually. So it's a network of 13, is that right? Or
there's 14.
14 hospitals and clinics throughout the state. Next slide. I'm not going to belabor this point, but we did some calculations around, how many patients we need in order to kind of really prove or disprove that this study is this intervention is effective. And we concluded that we need 520 patients to detect with reasonable power or certainty that that the intervention increases colonoscopy utilization, and we're by 12%, which is our goal that would be, we think, clinically meaningful. And so to achieve that goal, we would recruit 550 total patients. Next slide. And again, here's the basic schema. So patients would enroll, they would get randomized to either receiving the text or they would get their usual care. If they were enrolled in the texting arm, they would get text messages at 6 months postoperative, 7 months postoperative, and 8 months postoperative. And then we would follow their outcomes. We'd conduct some surveys of patients and physicians along the way. And then we would look at their health records to see if they got the colonoscopy or not, and what other tests they got, CEA and CT scan. Next slide. Actually, if you can skip the slide for 1 sec, and we'll come back to this. There we go. Here's the our sample of what we want to include in the the language that we want to include in these texts. So the basic message in the first text is, this is what the guidelines indicate, that it's important to do a surveillance colonoscopy at a year from surgery, and then we give them the number for the GI clinic that's associated with their hospital that would perform the colonoscopy, and then we would ask for a response from them and ask them if they've already scheduled their colonoscopy, yes or no, and then how motivated do they feel to complete the colonoscopy. And then we would measure that over time, the subsequent 2 texts. And the wording would be slightly different with each text that they receive. So the idea is to sort of continue to not bombard with messaging, but sort of give this at a reasonable frequency and more than once, so that this message sort of sinks in, and we're really kind of aiming to overcome the barriers that I mentioned earlier, the trouble with scheduling, the lack of knowledge, and maybe the lack of desire to go through with a test that may not be perceived as an important part of surveillance. You can go back one slide now. So in preparation for this larger study, our goal is to first conduct some focus groups to really make sure we're sort of on target with understanding the barriers to doing this test. I mean, we know that across our region, surveillance colonoscopy is only utilized 50% of the time. So, what are all the barriers beyond what we think are the barriers? So maybe there's something that we're missing. We want to understand all of the issues that go into this. And then we also want to understand, do we have it right in terms of the content and the messages that we're sending out, the frequency that we're proposing, the timing relative to the surgery, and so forth. And we're planning to assemble focus groups. Hopefully, many of your members would be interested in participating, but patients in Washington with, who are roughly similar to the patients who are hoping to recruit in the study, the randomized study, but a little bit broader in that they can be anywhere within 5 years of diagnosis, but not yet recurrent. And so certainly if this sounds appealing and of interest, we're definitely happy to work with you all to send information on how to participate to your Washington State members. And I think we can advance a couple slides to make sure I don't have any. Yes, I think that's all. I'm happy to take questions about this, or if there are questions that have come up about the previous presentation Dr. Issaka gave. We're happy to. We have plenty of time, it looks like.
Thank you both for your presentation. That was a great presentation. And to your point, as far as focus groups, one of the questions I was going to actually ask was if you all had ever worked with patient advocates or research advocates in the study design. And so I think having that patient input and that patient advice and it being a way to understand the barriers that do exist around these screening modalities is really strong. So to that point, do you guys interact with research advocates in any other setting, or in these studies, have you had any type of research advocates in the design or the IRB?
Well, so this is just in its very initial stages, and so we're really just starting the process of trying to engage patients by doing these focus groups, and then we can certainly go from there, and we would be very willing to have input into the design of the study and other aspects. But I think that in general, many high core studies that have come out of our research group have really used or tried to incorporate patient advocate input and patient advocates into the design of the study, and it's been exceedingly helpful. This is part of what's being done through Southwest Oncology Group, SWOG, which is another research entity we're involved in. And so I guess I we agree with your comment that it's extremely valuable, and we hope to do more of that.
That's awesome. That's great. And just a follow-up question: what is the timeline on this in-process study? When do you think you'll begin this data collection and whatnot?
So the focus group, we're hoping to assemble this fall, September timeframe, and September, October. And then we're planning to submit this grant in February, March timeframe.
Awesome. So we got
the bigger study wouldn't happen for probably at least a year after that.
Okay. Well, that's good to know. Thank you. Another question we got from one of our advocates, it says colon prep is a frequently cited disincentive for those considering repeat colonoscopy. Is there any discussion of other than traditional prep methods as you look to get your patients to come back?
Yeah, that's a really good point. That probably is a barrier. And so in this particular study, we're not really addressing the prep per se. The prep is sort of at the discretion of the GI clinics that they'll be working with. We're essentially just encouraging the use of the colonoscopy. But possibly Dr. Issaka can comment on sort of where things stand with newer preps that might be more accommodating or comfortable.
A lot of the logic behind and the research behind what we've put together is that this is a patient population that's been diagnosed with colon cancer before. And so unlike a population that's naive to screening, they've gone through the process before, and they would know best if, let's say, the prep that they completed with their initial procedure that led to the diagnosis, for instance, was very uncomfortable. And so in having that knowledge, we hope our intervention will just re-engage them with their providers and allow for that conversation to occur. So we recognize that this is going to be just a much savvier patient population, more knowledgeable, because, they've gone through this before. And if those are issues that are preventing, sort of re-screening or surveillance, then hopefully we'll be able to discover that with our project, because part of it is a survey that goes out to these patients before and after the intervention, where we ask them different questions related to the intervention itself and also their experiences with completing the surveillance. But as Dr. Shankaran mentioned, we are leaving that final choice of what to use up to the individual gastroenterology providers.
Great. That was a good question. Thank you, Frank. So another follow-up question I had relates to message targeting. Do you know if there's any research out there, or do you think that messaging should be tailored or should be targeted to certain age groups or race or income brackets? Do you think that's a barrier if it's not targeted?
You mean the content of the messaging should be modified based on the group?
Correct.
That's a really good question. I think we should aim to. So I mentioned earlier in the presentation that you can reach a variety of people via SMS, but I didn't touch on the question you're asking. Is yes, you might be able to reach them, but can you actually meaningfully reach them by sending a similar message to everybody? And I think that's a good point, and hopefully something we can dig into a little bit in the focus group. Definitely, with anything like this, you want to keep the message simple and the language simple and target to no higher than a 7th grade literacy level. I think that's true for most consent forms and that sort of thing. So we aim to keep that in mind for sure.
Great. That's great. Well, that is all the questions that I have. I just want to give everyone on the line one last opportunity. If you have any questions, now is a good time to type them into the chat bar or go ahead and unmute yourself. So I'll see if anyone else has any questions on the line. All right. Well, I think that is all the questions we have for today. I want to thank you both again for such great presentations. This was really insightful to see the work that's being done in the screening realm. And we really appreciate your time. So thank you very much, and I hope you guys have a good weekend.
Thank you so much for having us.
All right. Thank you, everyone. Have a good day.
Thank you.
Bye.